we have a quorum, and it is also the time for the meeting. We have arranged for 2 meetings to deal with the agenda items. After the first meeting, there will be a break of 10 minutes, and the second meeting will start at 5:10. I'd like to remind members that if you have any direct or indirect pecuniary interest relating to the items under discussion in the agenda, please declare the nature of such interest before you speak according to Rule 83A of the ROP. I would also draw your attention to ROP 84 with regard to voting on an item with which you have pecuniary interest. Item 1, FCR bracket 2015-16 1. Recommendations of the Establishment Subcommittee made on the 11th of March 2015. And that is that the items in paper 18, no members have asked for singling out any paper in that paper for voting. Any questions? If there are no questions, I will put this item to the vote. Those in favor of FCR 2015-16 1, please raise your hands. Those against, please raise your hands. I am of the view that the majority of the members voting are in favor of the item. The item is endorsed. Item 2, FCR 2015-16 2, recommendations of the Public Works Subcommittee made on the 11th and the 18th of March 2015. And that is PWSC 2014-15 50. 53 and 55. No members have asked for singling out any of those papers for separate voting at the FC. If members have no other views or questions, I will put the item to the vote. Will those in favor of paper FCR 2015-16 2 raise their hands? Those against, please raise their hands. I am of the view that the majority of the members voting are in favor of the item. The item is endorsed. Item 3, FCR 2014-15 59. Recommendations of the Public Works Subcommittee. And there are 5 of such proposals. 4 of them have been endorsed at the meeting held on the 20th of March. We will now carry on with the discussion of the remaining item, and that is PWSC 2014-15 49. This proposes the upgrading of part of 160 DS and part of 346 DS entitled Twin Woon Sewerage, Castle Peak Road Trunk Sewer and Twin Woon Village Sewerage to Cat A. And these have to do with the sewerage system for Castle Peak Road. And the estimated cost is $722.5 million in money of the day prices. To answer members' questions, we have Ms. Amy Yun, Assistant Director of Environmental Protection, Mr. Daniel Chung, Director of Drainage Services, and Mr. Tai Wai Man, Chief Engineer, Project Management, Drainage Services Department. At the meeting on the 20th of March, Mr. Raymond Chan and Mr. Leung Kwok Hong have already spoken on the item. And in the list of members waiting to speak, Mr. Leung Kwok Hong has asked for a second round. I will make use of the questioning arrangement we used at the last meeting. And there will be 5 minutes for each member in the first round, 3 minutes in the second round, 2 minutes in the third round, and 1 minute in the fourth round. Mr. Albert Chan, first round, 5 minutes. Chairman, with regard to sewerage and sewage treatment, I have no objection in principle, especially in populated villages. All these years, I have made many proposals, and I understand the administration is actively considering doing something for remote villages. And I'm asking about timing and cost effectiveness. And that is whether in terms of sewage collection, whether you would design independent sewage treatment systems without having it connected to the main system, so that the project cost will not continue to rise, and so that the project will not be delayed just because of the size of the population. I thank the administration for saying they will actively look into that proposal. However, with regard to the sewage collection systems already built over the years, I'd like to ask the same question, and I'd like to make the same request. I'd like you to implement a change, but you have still refused to do it. And my request is, when you connect these systems, the present plan is to have the connection point very close to the village houses. I have to declare interest. I live in a village house, and recently the administration is consulting my village about a sewage collection system, so I'll have to declare that interest. And my question is, in different villages where the geography is different, the connection point may be nearer or farther away from the houses. It may be from 10 to 20 feet, or it may be as far away as 100 feet. It affects the desire of the house owners, whether they like to connect to the system, because it may cost differently. Some people don't want to do the connection because the connection point is too far away. Right now, the unit cost is already $500,000. Sometimes the unit cost exceeds that amount. In other words, you build a system and then you are almost subsidizing each village house with $500,000. However, the connection will just cost a few $1,000s or up to $20,000. But if they do not connect to it, then you would have built the system. You would have subsidized it with $500,000 to provide the connection point. But if they are unwilling to spend a few $1,000s, there will be no connection, and the sewage will still flow into the stormwater drains. So I'm asking you about cost effectiveness and vis-a-vis the unwillingness of villages to do the connection. At the last meeting, I asked for some figures about the last 10 years and how different villages have done. I have asked for the percentage of connection in each village, but you have not given us the information. You always say 80%. It's just a ballpark figure. But you should have figures for each village, shouldn't you? You must have that figure. This paper is PWSC 137, 1415, submitted to the FC or PWSC on the 20th of March. Ms. Yun. Thank you, Chairman. About the information that is asked for, we go for a catchment area concept. If we look at the coverage of a project, we think we should do so on the basis of the catchment area. And in fact, over 80% has connected to the system, and the situation is not that bad. Village houses are not the same as housing estates in the urban area. In urban areas, the density is closer, and I can provide one connection point for an entire estate. But in a village, you have to do the connection for each house. Before the project starts, we have to step up communication so that the connection points will... Please do not beat around circles. You have been repeating the same thing for a few years. I won't trust that there is over 80% connection, and that is why I'm following up. I want figures for each village. I would want to expose the lie you are telling. I don't believe that there is connection up to 80%. I want to check the figures for each village. If you just give me the concept of catchment area, well, I won't have the ability to verify it against a big catchment area. Ms. Yun, Well, until December 2014, 8,600 odd village houses have connected to the public sewage system. And we say there is 80%. And the accurate figure is 85%. Why don't you give me a breakdown for each village? He is asking you for figures for each village. Do you have those figures? If you do, can you supply the figures later? If you don't, say so. You are telling us 8,000 odd houses have connected to the public system, and the overall percentage is 85%. But do you have a breakdown for the villages? We have not compiled those figures. You just don't have those figures. This is because each village is different. We have submitted information about some projects that were completed over 10 years ago, and the connection was over 90%. But there are villages which are still being provided with the system. The system may be built, but then the village houses are still connecting to it. Well, but it is just that it has not been completed. It is not that the figure will remain low. So I just like to ask a very simple question. Is it that you just won't have a figure for each village, whether the connection has been completed or not completed, but would you compile a percentage figure for each village? You can tell us how many houses have connected to it, how many are doing it, how many don't intend to do it. I mean, do you have the figures? Look, do you have them? I don't have them here. You don't have them here, so you have them at the office. I will go back and have to organize the figures. You mean you don't know? The question is, if I have built the framework of the sewage, sometimes there aren't even the houses yet. In other words, after the project is completed, the situation may still evolve. Well, you don't get it. So it's sometimes very difficult for me to process questions and answers between members and officials. I have already repeated myself 3 times, and I will ask it one last time. Do you have the figures? If you don't, just say no. If you have, you just say, I'll give them to you later. Just now, it seems you don't even know whether you have the figures. So do you know whether you have figures? Can you get a colleague to ask whether you have the figures Mr. Chan is asking for? Well, we have to do the counting. I'd like to, how much time will you take to do the counting? We have worked on 170 villages, and some projects have been completed 10 odd years ago, and the connection rate might have changed because houses have been completed after the project is over. Please don't beat about the bush. Perhaps you should ask another colleague who can answer questions to come here. Mr. Chen, sorry, I cannot help you. Go for a second round. You will have 3 minutes in the second round. No, Chairman. Why I am pushing for an answer, and I thank the Chairman for attempting to ask officials to answer my question, because the 80% odd figure is quite convincing for many members, and you are using it to lobby members. And then I will say you are not accurate, but you say that is the overall figure. And when I asked you for a breakdown for the different villages, you don't even have the figures. So how can you come up with an overall figure of 80%? This is so baffling. You say some projects have been completed a decade ago, then you can just let me know what happened at that point when the project was completed a decade ago. That is good enough. If you tell me 80% for that year, I would accept it. Well, maybe as times change, there will be new territories, small houses, and I'm sure they have to connect to the public system before the lands department would give them permission to build. So the percentage would only go up, not down. And therefore, it's just not reasonable for you not to have the figures. It's a matter of whether you want to provide them or not. Even if you count by catchment areas, you can still have figures for each village in each catchment area, and then you can come up with a general figure of 80%. If you are not willing to provide a figure, then I'm really thinking that your colleagues are cooking the books. I'm not talking about you, but they may be falsifying some figures. So they are not happy or willing to give you the figures, and therefore you can't even give me the figure when the chairman is helping me to push for an answer. I won't block the item because I support the project, but I just like you to complete the entire picture for us. Because I'm questioning whether the system is cost effective. You are subsidizing each house with $500,000, and if you do it, just a little bit more, people would be connecting to it. I think you are quite foolish now because you don't allow the public sewer to go directly to the houses, so people themselves do not have to do the connection because some people are unwilling to spend the money. So what you are doing is quite foolish, and you are not doing a good enough job. If members have queries about our figures, we can go back and try to submit more detailed figures. But if you are only talking about this item, the districts support the project. Well, he is not saying he doesn't support you. He is only asking for figures. I think you should answer briefly. If you know you have the figures, just say yes, and then you can give them the figures later. And if you say you don't, then maybe you need 2 months to organize the figures. If you have a ballpark figure, I'm sure you have the smaller items. Well, yeah, I'm just repeating what you have just said. No one is blocking you. We just want the figures. Just say yes or no. If you have it, can you submit the figures? We can go back and organize the figures. Mr. Tam Yu Chung, 5 minutes for the first round. In fact, I discussed more or less the same thing with the government. The policy is they would not directly have the system go to the villages because they say that may involve private land, and they say that has always been the objective of the government, and they have been quite recalcitrant about it. And of course, the environment is different in different villages. Some houses may cluster together, some are quite scattered. And village houses don't want to do the connection because they have to spend money, and then after the connection, they will have to pay sewage charges, and sometimes the houses are left vacant, so they don't want to connect to the system. And sometimes the house is inhabited only by elderly people. Therefore, these may be the factors. If you say the figure is 70%, 80%, we just want to have a deeper understanding of that. And still we have to support it, or else the sewage will go to septic tanks. If there is a more systematic way to collect sewage, it should be good for the overall environment. And it will convenience the majority of the villagers. So we support it. As to why it seems the figures are very complicated and it's so difficult for you to submit them, I don't understand. Well, maybe you think it's very time-consuming to count the houses in each village. But no matter what, whether it's 70% or 80%, we're going to still to support you. Ms. Yun, so you know the position. Go back and dig up the figures and give them to us in written form. Does any other member want to speak? If no other members have questions, I will put the item to the vote. Those in favor of PWSC 2014-15-49, put up their hands. Will those against put up their hands? I think the majority of members voting are in favor of the item. The item is endorsed. Item 4.
FCR 2015-16-3. Members are invited to approve a commitment of $4.033 billion for the provision of a loan to the CUHK Medical Center Limited, a wholly owned subsidiary of the Chinese University of Hong Kong, for the purpose of developing a non-profit-making private teaching hospital to be named the CUHK Medical Center. On the 16th of March 2015, the Food and Health Bureau consulted the Health Services Panel of this Council, and I would like to declare my interest as your representative, your elected representative, to be a member of the CUHK Council. To answer members' questions, we have the following officials in attendance: Dr. Ko Wing Man, Secretary for Food and Health; Mr. Richard Yuen, Permanent Secretary for Food and Health, Professor Fok Tai Fai, Pro-Vice Chancellor, CUHK, Dr. Fong Hong, Executive Director, CUHK Medical Center. May I now invite Dr. Joseph Lee to report on the deliberation of the Health Services Panel on this item. Chairman, at the meeting held on the 16th of March 2015, the Health Services Panel held a discussion about the proposal to provide a loan of $4.033 billion to CUHK to enable the Chinese University of Hong Kong to set up the CUHK Medical Center. Members did not object to the submission of the proposal to the Finance Committee for approval. Members are of the view that developing a hospital in CUHK can enhance the total capacity of the healthcare system. But some members are concerned about the way the teaching hospital would be operated and whether this would lead to shortage of teaching manpower in the medical faculty of CUHK. Some members are concerned whether resources of the Chinese University teaching hospital will be utilized and affect the services provided at Prince of Wales Hospital in the public sector. And also they are concerned that some of the doctors engaged by the CUHK Medical Center will not be under the employment of CUHK. And they are concerned that whether they would they should be non-CUHK employees so as to make it a clearer distinction between and enhance the training capacity. Some members want the CUHK to take over the new cases of specialist outpatient clinic referred to by the HA, and also to come up with criteria for referral, scope of service, and monitoring mechanism for efficiency and operation performance. But at this time, no details have been set. 5 minutes for the first round. Dr. Kwok Ka-Kay. But this is somewhat different from past projects. First of all, the government is going to provide a loan to a private hospital. Yesterday, we talked about the consultation on the voluntary medical insurance scheme. A few years ago, the FS earmarked $50 billion for the improvement of healthcare services in Hong Kong. When we talk about primary services, whether in the hospitals or in the clinics, a lot of resources and funds will be required to support their operation. And now $4 billion will be offered as a loan to a private hospital. If it's running well, then of course we don't have any problem. If not, the government will have to shoulder a big responsibility because less of patients have to wait for years before they can have operations or to have a scanning done. And the waiting list at elderly health centers is in terms of years. And now the government is offering a loan to operate a new private hospital. If the government is willing to inject billions of dollars to North NT East to patients who cannot afford to patronize private hospitals, then the service can be improved a lot. But now the government is putting the priority in the wrong way. According to the FS, well, we should accept the plan first. This is just like a deception scheme. It's a scam, and the government is trying to cheat people. And then I want to turn to conflict of interest. And many years ago, medical faculty members can take on private cases, but they cannot pocket the fees because the teaching staff were employed, 100% employed by the hospital and the medical faculty. And we know that medical faculty teaching staff are paid well to serve the public. And now you want to make sure that there will be two different sessions I don't know whether the professors and teaching staff will have to clock in and clock out to register the two different periods. In the past, the income will be used by the university for research purposes, to fund research projects. And now, of course, the government will pay money to the medical faculty, and some teaching staff may be able to take on additional jobs as if they were working part-time. And it's difficult to differentiate which is which. For the same patient, if you go to the Prince of Wales Hospital, you have to wait for a long time. But if you go to this private hospital, you can get treatment immediately. So since when has Hong Kong become a place whereby the waiting time is determined by whether you are a rich person or not? And now you are making the poor faring even poorer, and the rich will get much better treatment. Secretary, we understand many members are concerned that the government may be using resources to develop services in the private healthcare sector, but our policy is very clear. On the one hand, we are going to give greater support to services and development of services in the public sector hospitals. For example, we started the phase 1 of the expansion project of the Prince of Wales Hospital. The second phase is about to start. To tie in with the voluntary insurance scheme proposal, and to enhance service capacity for the middle class, so as to alleviate the pressure and the long waiting time faced by public hospitals. If 7 million people of Hong Kong, rich or poor, without means, will go to private hospital because they don't have any choice, they cannot go to patronize private hospitals, then there will be great difficulties for the healthcare system. Let me stress again that the government will continue to invest in the public healthcare system so that the development can be sustained. On the second question, I would like to defer to representative from the CUHK to offer an explanation again. Professor Fogg, thank you, Dr. Kwok, for your questions. It's said that with this teaching hospital, full-time professors of CUHK be willing to see more private patients. This will not happen. Some 30-odd years ago, when we established the medical faculty at the CUHK, we have put in place the same arrangement. All clinical professors, medical professors, can have 2 sessions of consultation or 8 hours per week for private hospitals without any restriction to the location. With this private hospital, the arrangement will still remain the same, but it will be subject to closer monitoring. Dr. Kwok asked if we are asking them to clock their service hours. We do monitor the time clinical professors spend on private cases. This will be maintained in the new hospital. In the past, the income was shared by the faculty and the university. Can you consider this to avoid any conflict of interest? At present, the arrangement is that the professor can approximately get a share of 1/4 from the income received through the private patient cases. But of course, I can consider Dr. Kwok's proposal. Dr. Helena Wong, in the panel, this submission was discussed at length. In the paper, it said that the $4 billion will be provided by giving a new commitment under the loan fund for the purpose of promoting private hospitals. This case is different. It's a private hospital. It's also a teaching hospital. At present, your teaching hospital is a public hospital. With this new commitment, this new loan of $4 billion plus to the CUHK, what measures are you going to take? Or do you have any plan to make it an established policy? And that is in the future, other private hospitals can ask for financing help of interest-free loans from the government. Would that become an established policy for private hospitals? Let me talk about the principle first. We have to look at the nature of the project and the proposed arrangement of a CUHK, and also the timing. All these factors are in line with our proposed reform in that we would continue to improve services and facilities in the public sector, and also promote the development of private hospitals at the same time, so that those who are in the middle class, who can afford to go to private hospitals, can do so, so as to relieve the pressure faced by public hospitals. And now the CUHK Medical Center will be pitched at serving the middle class, and it's in line with our policy development. So we think that this is an opportunity to take forward the proposal. Of course, our principles, as I've said, will not change. If there are other proposals, then we have to take a look at them to see at the time what's the need for enhancing capacity in the private sector. We're talking about 4,000 beds in private hospitals. We need to expand the capacity, but not without a limit. If at the time we believe that the capacity is already at a suitable scale, then we have to do the assessment, and we have to make a decision at that time. Will this become a president's case, a policy to those who would like to operate private hospitals, that they can refer to the case of CUHK's private hospital project, so that if they are willing to take on a certain number of cases from the HA, they will be offered an interest-free loan from the government? Well, if what they propose, well, actually this proposal is in line with our current policy, but I cannot say that this is a precedent, and in the future everyone who is in the same situation or who is willing to do the same thing will get the same treatment. We have to do an assessment then to see if we need more private hospitals at that time. We need more now, but so we welcome proposals like this now. Let's say sometime in the future, and we think that we have a sufficient number of private hospitals, then I don't think this can be referred to as a precedent. So, Secretary, you are saying that if we approve this project of CUHK, then in the foreseeable future, let's say a year after today, there are other private hospitals seeking financing assistance from the government. Then, Dr. Kuo, if we are just talking about the window of 12 months in the future, is it going to be favorably considered? Well, this is from a university. It's going to be used as a teaching hospital. So we are confident that the CUHK has the expertise and experience in terms of manpower, in terms of experience. And this is also a non-profit making project. If someone proposes a project, I will have to assess it in accordance with our criteria and principles. We look at our needs at the time. Mr. Wong Kok Heng, thank you, Chairman. I support this item. I have a question for the Secretary. Some time ago, some people said that this new hospital, the once commissioned, will be a base for piloting some collaboration between the Western medicine and Chinese medicine. This will be an innovation. So my question for the government and the university is this. Well, what do you say about this idea of piloting new arrangements in collaboration between Chinese and Western medicine? I defer to Professor Tai from CUHK. Well, CUHK attaches importance to collaboration between Chinese and Western medicines. There is a high demand for Chinese medicines, and many people who are seeking treatment from practitioners of Western medicines will seek assistance from Chinese medicines if the Western medicine doesn't work well on their cases. And now they would just try to get occasional help from Chinese medicine. With the assistance of the Jockey Club, we have a joint clinic in Prince of Wales hospitals. The doctors from the two streams would jointly provide consultations so as to come up with the best treatment, best plan for the patient. In this plan, hospitals, we are going to do exactly that. We have already reserved space for the joint clinic so that we can bring maximum benefits to our patients. How many Chinese medicine practitioners will be working jointly with doctors in Western medicine? Well, what you have said is good news to many patients. At present, the so-called joint consultation is that when a patient doesn't get any good result from seeing doctors, they'll try to get to a CMP. But if joint is a joint consultation, then both streams, both doctors from both streams will be there to provide consultation. That will be an innovation, a new leaf in our medical history that would benefit many patients. Can you elaborate a bit on this subject? Let me, for example, illustrate by some example. If it's a cancer case, and if you want to kill all the cancer cells, then Western medicine is much more effective than Chinese medicine. But if you want to handle pain arising from cancer, Western medicine has only a limited range of medicines. Very often the morphine is used. But for Chinese medicine practitioners, they can use acupuncture, which has been proved to be very effective. So we hope doctors from both fields, both streams, can jointly help the patient by offering treatment and by offering help to treat the pain symptoms. And also in terms of prevention of disease, or to strengthen the physical conditions of a patient, Chinese medicine is also effective. For example, for elderly people, they want to prevent disease, and we believe that collaboration between the two streams of doctors will be effective. How many Chinese medicine practitioners will be offering the joint consultation service with doctors in Western medicines? And what's the share of outpatient clinic and inpatient?
Well, I'm sorry I can't give you the exact figures at the moment, but the Western medicine practitioners are also very keen towards working with the Chinese medicine practitioners. But we need to recruit more Chinese medicine doctors, and we will try to encourage more doctors to join the scheme. But I can't tell you the exact figures now. Do you have the number of inpatient quotas? Now, we have not reserved hospital beds only for Chinese medicine treatments, but if necessary, we can provide such service. I hope you can roll this out as soon as possible. Assembly Lau. Thank you, Chairman. Chairman, on Wednesday, Professor Falk and his team came and briefed the Democratic Party again on this paper. Well, Chairman, giving assistance in the development of private hospitals is not a bad thing, but earlier on at the PWSC meeting, we were discussing the redevelopment of the Buddhist hospital. It's been 40 years, and there hasn't been any redevelopment or renovation. So as far as one country and two systems go, we have two different groups of people in society. When you go to a public hospital, secretary, you know that you need to wait for 6 or 7 hours. If you visit the specialist, you need to wait for 2 years. So I'm wondering whether we could do more in terms of public health care before we assist private hospitals. Is this the only way out, by helping private hospitals so that more patients can be diverted to the private sector? And we don't have enough doctors in Hong Kong. I ask you to allow the second generation of Hong Kong immigrants who are medical students to come back and practice in Hong Kong, and the answer outright is no. Well, of course, if you want to recruit doctors for the CU Hong Kong Medical Center, you will offer higher pay, and doctors from public hospitals would switch to the private sector. Now, please answer me this question on this hybrid model, because it's neither here nor there. Just now, when you answered Mr. Wong's question, or Dr. Leonard Wong's question, you agree that this is some sort of a precedence, because other private hospitals would come up with proposals and ask you for help, and that would amount to billions of dollars. Secretary. Well, let me reiterate that we don't regard this as a precedence, and we will not accept any proposal simply because we have this as a precedent. We need to consider the capability of the proponent in developing a private hospital and the experience. Now, in terms of development of private and public hospitals, there must be a balance. In fact, for the teaching hospital, very soon the proposal will be submitted to the FC. As for the Buddhist hospital, it has gone through the stage of PWSC, and once we have the approval of the FC, we will proceed with it as soon as possible. This year, as far as new developments and redevelopment of old hospitals are concerned, we have a commitment of $81 billion. So on the one hand, we will expand public hospitals' service capacity. On the other hand, we also need to develop private hospitals, because we have middle-class citizens in Hong Kong who have the means to use the service of private hospitals. Well, if people in Hong Kong would like to go to private hospitals instead, then why can't they arrange for financing themselves instead of asking for a loan from the government? Well, when we develop the healthcare sector as an economic sector, definitely for the consortia, they have the means. However, for a tertiary institution, that's a different picture. I understand the CU Hong Kong has tried very hard. Well, perhaps we should ask Professor Falk to explain this. Thank you, Chairman. Thank you, Ms. Lau. There are two reasons why we're not taking out a loan from the private sector. First of all, when we were given the site in Tai Po, we discussed with the consortia on putting up bids for the tendering of the typo site. But our philosophy is this: if we want to provide service to those in the middle class or even the grassroots, we should provide affordable service, and the pricing should be transparent, and the objective should not be to maximize profit. If the consortia are involved, then definitely we won't be able to achieve the objective. And secondly, we can't mortgage the land or assets because this is these are public properties, so the loan will be unsecured, and we won't be able to raise such a sum. $4 billion is very huge. Well, may I also supplement, Chairman? As far as manpower is concerned, at this stage, manpower is tight. However, we have been working on improving the situation. We have increased the number of places in medical schools, and will also enhance the capacity for training of doctors and healthcare staff. As for non-local doctors, through working with the Hong Kong Medical Council, we have made some improvements, including the increase in number of examinations, and the passing rate has also gone up. And we have also implemented an arrangement for specialist doctors who have passed exams to shorten their internship period. So this is so once the VHIS is implemented, once the private hospitals are built, then the manpower coming on stream should be able to meet the needs. Professor Joseph Lee, I have a number of questions on this item. You're going to provide a loan of $4 billion to Hong Kong, CU Hong Kong, for the CU Hong Kong Medical Center. What is the relationship between this medical center and the university? Well, there have already been suggestions that manpower will be drained. I'd like to know what is the relationship between the CUHK and the medical center. Well, according to the paper, this will be a private teaching hospital. So CUHK already has a medical school, and the Hong Kong U has one as well. Now, you're confident that with a $4 billion loan, they will be able to build this hospital. What about Hong Kong U? Do they have private teaching hospital as well? Well, perhaps they don't need a loan from you, but is it the case that, in fact, even for medical schools or universities, they also have teaching arrangements in private hospitals? And the third question is this: you are going to build this hospital in NT East, and if necessary, referrals can be made to this CUHK Medical Center. So after this center is commissioned, in terms of service capacity, how will the situation for NT East cluster be improved? Well, say if the case is referred to the CUHK Medical Center instead of Prince of Wales Hospital, North District Hospital, etc., how will the situation be improved? Well, let's say I originally opted for Prince of Wales Hospital, and then I was asked to be referred to the CUHK Medical Center, and then I have no money. What should I do? Well, three questions. Now, first on the second question. Strictly speaking, you can say that, in fact, there is a teaching element in each and every public hospital in Hong Kong, because for the teaching hospitals of the universities, because of insufficient capacity or other reasons, medical students would be arranged to receive training in other teaching or in other public hospitals in Hong Kong. As for Hong Kong U, I understand that at least there is a collaboration with the sanatorium and hospital for some teaching. So can we say that this is a teaching hospital? I hope members will understand that it's a matter of scale. For the remaining questions, I'll defer to the CUHK representative. Now, about the relationship between CUHK Medical Center and CU Hong Kong. First of all, financially speaking, they're totally independent of each other. If this is a university-supported teaching hospital, definitely, or the UGC-funded teaching hospital, definitely, we won't be able to support its operation. There are clear stipulations according to UGC, and we're not allowed to do that. So financially, it is independent of CUHK. However, as far as teaching is concerned, is related, because all full-time doctors recruited in the medical center will be asked to be tasked to teach as well. So they have this responsibility of providing teaching in the hospital and on developing new technologies and new treatments. For example, combining Chinese and medicine, Western medicine, and personalized medicine. It may be more difficult to implement these ideas in the HA. However, with R&D element in the CUHK Medical Center, we believe that it will be much more convenient to try out these ideas. What about case referrals from the Prince of Wales hospitals? Well, what is the estimated change in the service capacity in the cluster with this new hospital? Secretary. Well, I'll defer to PS Mr. Richard Yun. Our agreement with the CHK is this. As far as specialist outpatient clinic is concerned, they will provide up to 17,600 new SOP cases and 6,600 day surgery cases each year. And subject to this approval, we will proceed with the detailed planning. Our preliminary idea is that the center will review. The hospital will review the waiting list, and if the waiting list is too long, cases can be referred to the CU Hong Kong Medical Center, and the fees will be charged at the level similar to the public hospital, and this will help shorten the waiting time in NT East cluster, and there is. And a CUHK's agreement with us is for an indefinite time. So this arrangement is applicable to other hospitals. So for patients waiting in the long waiting list, they can be referred to the medical center. And as this is a teaching hospital, these cases may also be beneficial to the center, as it can serve the teaching purpose. Next, Mr. Tony Chair. Chairman, in principle, I have no objection to this funding allocation, or in fact, this loan to expedite the provision of healthcare facilities. But I have a question. According to para 2 of the paper, the loan is for a period of 15 years, with interest free for the first 5 years. And according to the paper's calculations, the interest foregone is about $500 million. And just now, I heard that there'll be an agreement with the CUHK Medical Center. And then starting from the end of the 5-year period, cases can be referred to the CUHK Medical Center for SOP consultation or day surgeries, and the HA will stand to benefit. Say for the figures, 17,600 SOP cases and 6,600 new day surgery cases. I'd like to know how these figures have come by. Now, second question. According to para 6 of the paper, there are conditions of grant by the government. My question is, does the CUHK have to pay a land premium? If so, how is the premium calculated? Well, I'll try to answer the question, and I will invite the PS and the CUHK representative to supplement. Well, in our course of discussion, we asked the CHK Medical Center to provide some service quotas to us, but that would depend on the clinical situation of Prince of Wales hospitals, and depending on whether the waiting list is long or what, we will make use of the service quota to alleviate the pressure on that specialty in the public hospital. As for land premium, originally, the grant has been given to the CHK by the Education Bureau. And for some time, the CHK has decided to make use of this site for this purpose, and the land premium is set at $1,000, so that's really a nominal level. However, as set out in the details of the paper, the operation of the center is in line with our healthcare policy. So in terms of the arrangements of interest payment and premium, I'll see if the CHK has anything to supplement. P.S. For those two figures, now the interest foregone would be $500 million. And with this arrangement, the HA would be able to save up to $1 billion. Now, regarding these two figures, in the course of discussion, we agree with the CUHK that the center should run on a self-financing basis, and therefore, or self-sufficient basis. So the interest should be regarded as a kind of investment, and we must understand that the interest is charged at a floating rate, so it is an estimate, and it is a huge investment of $6 billion or more. And during the initial period of its operation, the surface capacity will increase gradually. If you require interest repayment starting from the first year, it will be a huge burden on them. Yes, I understand that, but I'd like to follow up on the other point, because only a nominal premium is charged for the grant of land lease, and I think that there are conditions attached, and the government will be monitoring its operation, because it is a non-profit making private hospital. What if it makes a profit then? Because the land premium is close to zero, and although according to your calculation the HA or the government also stands to benefit, in terms of the land lease, I'd like to know how the monitoring can be done. Well, land is granted to CUHK, but originally not for the purpose of a hospital. Well, I will ask Professor Fogg to answer your question. That is, what about the role of monitoring by the government? Well, this is a subsidiary company wholly owned by CHK. Secretary, you'd like to take the question? Well, let me try to address your question and see if Mr. Chair accepts my answer. Well, we monitor the center through the conditions of grant, and on top of that, we have an agreement. That is a service agreement.
All the conditions set by us will be included, and if the conditions are flouted, the government can re-enter the land. This is something we're going to watch closely at. Next round, Mr. Chair, you will have to wait for the next round. Mr. Lee Cheuk Yan. I think this is neither fish nor fowl. The Labour Party thinks it's important to develop the public system for medical service. But there is only a 0.4% for expenditure for the HA this year. And the HA will have to dip into its reserves in order to make up the $1.6, $1.7 billion. My worry is the impact on public delivery of medical services. Why do I say this is neither fish nor fowl? It is in a way public because it helps the HA, but then it is also private because according to it, this is also the first question, you say people can afford it and there is transparency. It's good to have transparency because private hospitals in Hong Kong do not operate with transparency. But what do you mean by affordability? It's quite vague. You mean this for the middle class. When you say it is affordable to the middle class, what kind of income are you talking about? What is the income bracket? I don't know. What do you mean by affordability? That's the first question. What is affordability in your mind? Secondly, this is going to have an impact on the public system anyway. Even if you say that the professors at Prince of Wales from CU will not have to work at this medical center. But in fact, they can still engage in private practice and then they go to the CU medical center. As you know, there is a big wastage of manpower in the public system. If the private system continues to get people from the public sector, then public medical services will be very much impacted upon. This is our worry. You say it is a teaching hospital and every doctor that works here will have to teach. Okay? That is the nature of a teaching hospital. But you already have two teaching hospitals, Prince of Wales and Queen Mary. Does it mean Prince of Wales will not be a teaching hospital anymore? What is the overall arrangement? The Labour Party is very worried about the impact on the public medical service system. If we want to improve our medical system, you say that this center will take over some cases from the HA. Why don't you just use the land for a public hospital to respond to the demand for public service in NT East? Instead of coming up with this proposal, which is neither fish nor fowl, why don't you just go for a public project? Secretary, I fully understand this because there have been views saying that this particular project will affect the development of the public medical system. I'd like to reiterate that we have committed to the long-term development of public medical service. And in fact, we are working very hard on this. We have told the panel on health services that we are going to expand the public system. There will be 6,000 to 9,000 more beds as a result. And in the budget, $8.1 million has been set aside for redeveloping or building new hospitals. Maybe you understand that the HA receives a block grant from us. If it can save money because of operational efficiency, we allow it to save up in a reserve which can act as a buffer. It has a healthy reserve now. And we don't think we need to raise the level of the reserve to an unnecessarily high level. And its reserve now is still quite healthy. The government will continue to allocate resources to public hospitals when there is a need. You are worried about the fighting for manpower between the public and private systems. Now there is an overall lack of manpower and therefore we are afraid indeed there will be competition. But before or after 2020, because of different factors, we have now more undergraduate places for doctor undergraduates or medical students so that we have a bigger training capacity, and also non-local graduates will be the subject of different arrangements. So by and around 2020, we believe when these hospitals are built, the voluntary health insurance system is up and running, then overall speaking, there will be some relief to the manpower situation. When that happens, there will be movements of people between the public and private systems, and that is only natural. As for the teaching hospital point, I'd like to defer to the CU representative. Professor Falk. Thank you, Mr. Lee. Mr. Lee is worried that the Prince of Wales Hospital and professors there may go to this medical center. I'm quite confident that will not happen because professors are being touted now all the time by private hospitals, but our professors do not leave because they like the environment in the university. Why? Because they can engage in research and development, and private hospitals are not going to provide the right conditions for doing research and development. And I'm talking about funding for it, the team that work together, and also the environment overall. So if you talk only about money, I'm sure all professors would have left. So the medical center is not going to affect the competition side. On the contrary, we will have a bigger teaching team once we have the medical center. We believe it will only benefit our teaching. Well, he asked about private hospitals. Since this is going to be a private project and you say it is within the affordability of the middle class, I know that has been discussed by the CU Council. I'd like to ask you whether you have thought about the future fee level. I can answer the question from two angles. By affordability, to a certain extent, it has some relationship with the development of the health insurance scheme. If the public make more use of private insurance, their affordability will also go up. Secondly, many people now patronizing private hospitals do not know exactly how much they have to pay. Upon admission, they may have an amount in mind, but when they are discharged, there may be a surprise waiting for them. So we think we can contribute to the system. And therefore, we would charge a package fee for 70% of the in-hospital services. In other words, patients will not have any surprise when they are discharged because they know the fee at admission. And number three, the fee level. We will look at the market situation, but basically, we hope we can be positioned at a lower level in the market. Ms. Alice Mack. When we were consulted on the VHIS, we met the insurance industry and patients groups. They said if we only rely on VHIS, we cannot solve the problems plaguing the system, and it's important to develop both public and private services. Some people in the industry have said that if we do not regulate the private fees, the premium for VHIS will go up, and in fact the VHIS will thus fail. This is what people in the industry say. If the government can give a loan to CU Hong Kong, and then the package fees will be charged by the future medical center, this is something good because private hospitals are not doing it. Professor Falk, can I ask you this question? You now think, first of all, 50% of inpatient bed days for services would be provided at packaged charges, and in the end it will go up to 70%. I'd like to know the timing and whether it will be aligned with the VHIS timetable. And also, is 70% the highest percentage? Can you increase it further. And also, in terms of transfer between HA and CU Medical Center, we were very happy to know that a medical center can take care of over 10,000 SOPC transfers in the future. The paper seems to be saying that starting from the 5th year, you can receive the transfers. No, but when will it start, and when can you help the public system? Can we be given a timeline? In fact, we can receive transfers from the first day of operation. The paper talks about the 5th year. It is just about increasing the volume, because at the beginning we might not have many doctors and nurses. We say we would spend 5 years so we can add up to 17,600 every year, but transfer can be accepted from the first day of operation. As for the package fee ratio, at the beginning, the target for the first year will be 50%, and for it to gradually go up to 70%. As for the timeline, it will be flexible. It would depend on the actual operational challenges. The private hospitals are saying that 50% may already be quite difficult. We hope we can achieve it. Can we further increase the ratio? I cannot say too much about the future because it depends on the actual operation. But we can't say there will be a big increase because we need cross-subsidizing from other services. Maybe we are going to sustain a loss by providing packaged fees. So we need a mechanism to do cross-subsidizing. Ms. Alice Mack, or Secretary, I'd like to add a point. There may be emergency situations at hospitals, and maybe some patients are not inpatients. So you can see that Dr. Fong cannot really tell you whether we can go up more than 70%, but as you know, sometimes you just cannot provide packaged fees because some patients come in for checking and examination, and therefore you don't know what you have to do for them at admission. Well, members are worried whether professors at the medical school now will go to the new medical center. In fact, I tend to agree with Professor Falk. I'm very confident in the lecturers and professors of CU Hong Kong. I also believe that they won't just go away for the money. But when the medical center needs to recruit doctors, as you know, this is also difficult for public hospitals like the one in North Lantau. It can only operate an A&E department 1 year after commencement. You are going to set up a new hospital. You say you will not engage people from the CU Medical School, but are you confident you can really engage enough manpower so you can provide the service you intend to provide? Professor Falk, we understand that is a big problem because we need quite a big number of doctors. But we are quite confident because we have 3 objectives. Number 1, we have talked to some doctors and they already want to leave the HA. But they don't necessarily want to go into the private market. It is not that the HA is not good, but the workload is such that people's family life and quality of life are affected. Well, I shouldn't say more. So there are people who want to go to a new environment, but they might not like to practice in the private market. And this will be another choice, which will be welcome. Secondly, the retirement age of the HA is quite early, in our view. We can hope to engage experienced doctors. And in fact, we have a figure in mind. We also have our retired professors. The CU retirement age is the same as the HA, which is 60 years old. So in these 3 aspects, we can provide manpower for the new medical center. Mr. Bill Tang. Chairman, looking at population in NT East, there is not a serious case of aging. The ratio of old people is 11 to 12%, which is lower than the overall ratio. Members were asking about waiting time at A&E and waiting time at SOPC. The waiting time is always very long, and we can talk about ENT, gynecology, etc. And some patients have to wait 24 hours to see a doctor at the A&E department. And I have seen information recently which is quite frustrating. The head hospital, Prince of Wales, only has 22 doctors at A&E department, and North Lantau 21 and Tuen Mun 40, if I remember correctly. And also QEH 28 to 29, Princess Margaret 28 to 29 again. And we only have 22. You say HA staff may not want to go to the private market, and they would welcome this because they know it is the same employer, and I'm afraid they would leave in drones. This is my worry, and also I don't understand. Well, the NT East hospitals are not that inaccessible, but why is it that it's so difficult for you to ask doctors to work there? There are so few doctors at Prince of Wales, and now you are building this new center, which is going to be a competitor. It's really worrying. And you say within 5 years you can achieve a break-even. But how? Are you going to do it with the charging of fees and charges? Secretary, can you answer the first question? The CU representatives may know the operation of Prince of Wales better than I do, but in principle, I should take the question. The same question has been asked on other occasions. I remember Dr. Chung also explained that the figures they provide may not actually reflect the manpower level. And secondly, the A&E department of Prince of Wales, why is it so difficult to get doctors to work there? There is one particular difficulty. The NT East has seen population increase quite quickly, and therefore there is a tight supply for inpatient service in NT East, and that is why it's rarely seen in hospitals where after stage 1 extension we would plan for stage 2 extension right away. It is very crowded in Prince of Wales wards. When patients have to be admitted, they face difficulty because there is a tight supply of beds. And if that is the difficulty faced by frontline doctors, and if there are other factors as well, they might not be happy to work there. But things have improved in the last year. Secretary, can you now comment on stage 2 extension? We are just doing the planning. Once we have the timetable, we'll report to the panel. But we are not talking about Prince of Wales today. Professor Fogg or Dr. Fong, why do you think you can break even after 5 years? This is our evaluation of the market, and we have considered a few factors. Number 1, the VHIS. Secondly, there is an increase in population in Hong Kong, and also the population is aging. There will be a bigger demand for medical services. And there will be pressure to be brought to be borne by the public service when the population ages. But in fact, there are elderly people, many of them who are over age 65, who can afford a private service, and that would create a demand. What is more important is that we also think that the public also have a demand for packaged services.
Because it's predictable, and that is a very good financial safeguard. Of course, we need to control our costs. And through effective cost control, can we be able to offer package charges? Otherwise, we would incur losses. Dr. Fernando Zhang, our main concern is that we are using public funds to enable the CUHK to develop a private hospital, albeit a non-profit making one. We know the CUHK medical faculty are conducting many cutting-edge research projects, and they have many experienced professors and experts. And these experts have been doing a lot of exploration and development in the Prince of Wales Hospital, and the patients that they serve are the general public. That's very good. But now we are going to see a CUHK hospital, and you have already said that the target clientele will be the middle class, with the invaluable expertise, knowledge, and even facilities be removed to serve just the middle class instead of the general public. And we are doing this through the support of public funds. That's worrying in terms of the philosophy. And that is to say, the general public will no longer have access to the valuable skills, knowledge, and diagnostic services offered by the CUHK medical faculty. Yes, you have said that you want to progressively increase the ratio of package prices to 70%. But you've also said that if they are for long-term treatment, you may refer them to public hospitals. For example, you may offer a package price if they would be hospitalized for, say, three nights. But if it's for 4 or more nights, you refer the patient back to the public hospitals. Of course, it's good for your financial planning and management as a private hospital. But the worry is that at the end of the day, for those who can afford to buy the services at package prices, or those who can afford because they have insurance coverage, will get better services. But other people who are unable to do so will get inferior services in the public hospitals. And for chronic patients, you will ask the public sector, public hospitals, to take care of them. So in fact, you are doing the creaming process. You just skim off the cream of the crop. So how can you assure us that this will not happen? Secretary? Professor Secretary, you want to say something first? Since Dr. Zhang has talked about the use of public funds, yes, this is about using the public funds to offer a loan. A loan comes from the public coffers. But we want to make the best use of the leverage effect. The middle class is willing and is able to afford services in the private hospitals, but the choices that they can get are limited. Beds in private hospitals are small in number, and many of them are forced to use public hospitals. But if we enable this project of CUHK to get a start, and then the middle class will be able to expand their resources to get services from such a private hospital to a greater extent, and there will be less demand on public hospitals. That is to say, for those who are willing to pay, who can afford to pay to get services in a private hospital, can do so while satisfying the needs in healthcare. The pressure and the subsidies offered by public hospitals will be reduced. So that's the leverage effect. As for the other issues, I'll defer to Professor Fogg. Thank you, Dr. Zhang, and thank you, Chairman. Dr. Zhang asked whether the research and the development projects will be transferred from Prince of Wales Hospital to the new hospital. And the second is the creaming issue. I'll defer the second question to Dr. Feng. For the first question, my answer is no. Well, this new hospital is self-financing. However much it enjoys in resources, the private hospitals cannot really support or fund research projects or pharmaceutical research. There's no way that we can have such a big team to support such research efforts. So whatever the achievements we can make through research, patients in the Prince of Wales Hospital will be the first group to benefit. And second, we'll be able to bring in new treatment and new protocols much more faster than the HA, because there are hurdles and there are procedures to follow for HA to bring in practices and treatment from outside. That's why private hospitals can act more quickly in this respect. But for the research team and capacity, they will largely remain in the Prince of Wales Hospital. Dr. Hong, we have a dual system in the healthcare sector. Apart from A&E, public hospitals also handle more complicated cases which require interdisciplinary consultation and treatment. Because the overall system and the network of specialties are all there. Even under the current system, such complicated cases are mainly handled by public hospitals. If we are talking about a small private hospital like this one, and given its principles of management, it will not be able to change the roles played by different parties and hospitals. What we can do is to offer package charges. Of course, we'll have to shoulder some risks associated with complications on unforeseen issues in the case. We will not refer the patient back to public hospitals just when we detect something unforeseen, which are not major problems. But of course, if the patient is in a very difficult situation, for example, requiring hospitalization in the ICU for over a month, then perhaps the better place for the patient to go is to go to the public hospitals. My mother has just been discharged. I have not got the time or the courage to ask her how big the bill is. You are going to borrow $4 billion from taxpayers. So my question is, what can we get in return? Of course, the public would like to see more benefits. The more the better. And what are the competitors saying? Their competitor will be a CUHK private hospital. And we have been told that the government has been trying to extract as much as possible to benefit the general public. I can feel that. But of course, as I've said, I want to get more benefits. You are a non-profit making hospital, so the more benefit, the better. You have promised to offer package charges to an extent. I've asked the CUHK to give me some financial projections. I won't go to details. I won't divulge the details. After the loan is fully repaid, you are going to have good profits. You have promised that you are going to offer package prices, and Kosher 2 is relevant. But this is good news for the middle class. And compared with other comparable private hospitals, the prices are lower. So it's good news for the middle class. That's the assumption. Some 70% of the services will cover by percentage prices. And that will give you a steady profit if your projections are fine. So can CUHK consider this? A non-profit making is a tricky term. Look at the URA. What is social responsibility? What is profiteering? There are a lot of controversies. They have got a new chairman. So what can you do with your profits? I won't mention the level. It's your private information. What's the profit for? If you offer package prices for 70% of the cases, why do you need so much profit? Why can't you offer package prices to a greater extent so that you would more or less break even, and you would benefit the middle class even more? I know colleagues from the Labour Party will say that you make a distinction between the middle class and those who are not middle class, and those who are not the middle class will have to go to the Prince of Wales hospitals. Well, let's set aside this argument, because the middle class is expected to pay for some of the costs, and by paying some of the costs, they get a better service. I just don't want to wait until I'm old enough to go to CUHK to petition for more to be done in offering package prices when I need them. Well, this hospital is a self-financing one, so it's very different from public hospitals. The public hospitals need to carry out maintenance and repair and upgrade their facilities. Everything will be borne by the government, but not this hospital. So the surplus will be used for such purposes. For example, for the MRI machine, for other facilities and equipment. They all have a limited lifespan, and they also have to do renovation and maintenance in due course. They will have to do all these by utilizing their surplus first. And if there's still surplus, the surplus is supposed to be used to plow back the surplus to support the services of the hospital. And this is subject to government agreement. So the hospital cannot use the money for other purposes of the university. That won't be allowed. Professor Tai, I believe that the Secretary has more or less said it. The accounts will be very much transparent, and we have to, of course, provide the accounts to the government. The Secretary is right, and we need to do maintenance, and we may need to expand, and we need to replace medical equipment. We need to fund all these through our surplus. And even if there's still a remaining surplus, it will be used on the hospital or on the teaching of students. And if we were to use it for other purposes, we need to get the consent of the secretary first. And that's true even after you have repaid the loan. Yes, it's in black and white. It's forever and ever. But where can we find it? Do you have a contract in the loan agreement? We are now talking to them for the lease because of the additional conditions. The service agreement will be part of the land grant, and will specify how they can utilize their surplus. And everything will be subject to the agreement of the government. It's all in the document, in the legal document. So it's in the lease. So even after the private hospital has repaid the loan, in the future, any structure on this piece of land that has resulted in any surplus will be subject to agreement before it can be utilized. But it's different if it's in the loan agreement. It's different. The service agreement. The land grant contains special provisions. There are additional clauses in the form of a service agreement. The service agreement is part of the land grant condition. So it persists. It lasts perpetually. So the CUHK and the government will sign a service agreement even after the $4 billion loan has been repaid. And this piece of land is CUHK's land. Any profit earned through the hospital on this piece of land will, on a permanent basis, be subject to prior approval before the surplus can be utilized. The surplus only, not the day-to-day expenditure. If they have a reserve and they want to spend $30 billion for an expansion, they need your approval. Well, the land is CUHK land, but they want to change the land use, so we have to enter into a land grant, another land grant, and with conditions. So they would do this they will impose this arrangement through the land grant conditions. Mr. Leung Ko-hong, 5 minutes for the first round. First, although it's a loan. I object to the thinking on the part of the government. Hospitals in Hong Kong are in now such a poor situation because the previous administration did something wrong. Many people use public hospital services because the services are good, and now the government would offer a loan and allow the land use to be changed so that a hospital can be built to serve mainly the middle class. Well, it's a laughable notion. Rich people use services in our public hospitals. It's nothing strange nowadays. I'm not discriminating against them. I want them to pay more taxes, just that the government is unwilling to ask them to do so. Now, without any good reason, you want to set up a new teaching hospital to serve mainly the middle class through the offering of package prices and so on and so forth. This is a strange notion.
I am a electoral member representing NT East, and I receive lots of complaints. I have quite a lot of middle-class constituents, but I don't think the middle class would say that more hospitals should be built for them. If you say the target group is the middle class, then the only criterion you should use is the market rate. You shouldn't ask the middle class. So that means we're providing a loan, we're giving land to CUHK for a private hospital for the middle class as the target user. So I think the government is sick. There is imbalance between public and private sectors. But it has nothing to do with me if there are insufficient beds for the middle class. And why should we continue to listen to this nonsense? Please explain to me. Is it because the middle class cases are the most universal, so that they are most suitable for teaching purpose? Is it because they come in a special form, or that there is something special about them? Please explain to us why. And I have another question. What is the proportion of the middle class in our population? Do you keep any statistics? What is the situation? Apart from price level, you cannot really reject other classes. Are you saying that the poor shouldn't use this hospital? Anyone from the administration can answer me. Secretary. About the concept of improving services in the public healthcare and private healthcare sectors, we have given this a thorough consideration. As for the problem with type 2 babies in Hong Kong, I want to point out that this government has already rectified the problem. In Hong Kong, we have this public healthcare system, which is funded by taxpayers' money. The service is available to the 7 million people in Hong Kong, and it is a highly subsidized service. Now, against this background, we have been aware of the problem with sustainability in the long run. However, the government's policy is clear. The public healthcare system continues to be the safety net for the 7 million people in Hong Kong, and the government will continue to stay committed in the development of the public healthcare system for everyone in Hong Kong. However, among the 7 million in Hong Kong, if the so-called middle class wishes to resort to private hospitals, the problem is there is insufficient capacity in the private sector at the moment. So on the one hand, the government will continue to commit resources to support the public system. On the other hand, indeed, the middle class, or there are some in the middle class with means, who would like to use the service, and if the service is available, it could help alleviate the pressure on the public sector. So the healthcare reforms idea is to have parallel development of the public and private sector as the long-term objective. So on the one hand, I need to reassure Mr. Leung that we understand that as far as NT East is concerned, with significant increase in the population in Sha Tin, after phase 1 expansion is completed, we are already planning ahead for stage 2 expansion. So this medical center will not affect our commitment in public hospital development. And it's hard to define what the middle class is, but there are indeed some who have the means to use private hospitals' services. And this is what we have heard in the consultation process. They are not able to do so because of insufficient capacity, and we're giving this opportunity to them. And there are also some who would like to use, but dare not use private hospital services. Apart from the problem with insufficient hospital beds, some are concerned about the fees and charges and the lack of transparency. Well, we call this the hospital for the middle class because, as Mr. Feng or Dr. Feng said just now, the fees would be charged at a relatively low level, and they will also use packaged pricing, so as to reassure the middle class who would like to use their service, because for up to 50 to 70% of the conditions, they can refer to the schedule for the package prices, and they can be reassured. So indirectly, this can alleviate the pressure on public hospitals. Dr. Kwokaki not here. Dr. Helena Wong, second round, 3 minutes. Thank you, Chairman. Now the question is this. This paper provides a summary of the service agreement between the government and the CUHK Medical Center. I'd like to know whether members can be, or the public can be given the details of the service agreement between the government and CUHK. Because there are a lot of areas we need to clarify. For example, this is a non-profit making private hospital, and it should be self-sufficient. And already some members ask where the profit would go. Would it be plowed back to CUHK Medical Center for healthcare purposes, or would it be submitted to CUHK for other purposes? And this is not explained in the paper. And in para 7 of the paper, starting from the 5th year of operation, the medical center would receive from HA up to 17,600 new SOP cases and 6,600 new day surgery cases each year. However, nothing is said about the agreement from the 1st to the 4th year. And according to the paper, it is estimated that for the first 5 years they would be able to balance the books. So my question is it the case that for the first to the 4th years, no cases would be received from the HA, so as to allow the medical center to make a bigger profit to offset the account, so that starting from the 5th year, it would be able to take up to 6,600 day surgery cases from the HA. So can you explain to us what is the percentage agreed for the first few years? Now, answering your first question, with Letchwell's approval, we will proceed with signing the agreement with CUHK. This I cannot make it available at the moment, but this will be made public in due course. Now, secondly, definitely there will not be dividends given to shareholders, and this is non-profit making hospital. So for the third question, I'll defer to the Permanent Secretary. Well, in enclosure 2, paragraph 2, it sets out the details of the undertaking given by CUHK, and it said that the CUHK Medical Center shall attend to a minimum of 3,520 new SOP cases and 1,320 new day surgery cases in the first year of operation, and the number of cases will increase progressively. and I'll see if Professor Falk has anything to supplement. I have nothing to add, but like PS said, we have already undertaken to take 3,520 new SOP cases and 1,320 due-day surgery cases in the first year of operation, and the number of cases will increase progressively until we can receive 17,000 plus SOP cases in the fifth year of operation. So it doesn't mean that after the interest-free period ends, you will not take up any cases. Well, Dr. Len Wong, you should queue up for the third round. Ms. Sit Ho, well, in fact, I didn't use your time. Well, Ms. Sit Ho, first round, 5 minutes. Thank you, Chairman. Both the government and the CUHK say that this is a non-profit making hospital. But now we see charitable organizations with the Section 88 status, which are private hospitals reaping great profits. And when you ask them not to take up so many bookings for the delivery of type 2 babies, they reject it, and it took a long time before the measure was implemented. So as far as the definition of non-profit making is concerned, there is we need to cast a doubt. Well, in particular, you cannot disclose the agreement at the moment, and we'd like to know more about the fees and charges. Even if it's packaged pricing, we'd like to know how fees will be charged. You say that the profit would not be powered back to CUHK, but will there be other ways to fatten the pockets of the management, and that the $4 billion loan from the government would end up to become a loan for the development of a private hospital? And if we cannot charge the interest at the market rate, we don't think it's worthwhile. So I think you should give us the service agreements for reference first, so that we won't feel like we're signing a blank check. And let us know all the details before we vote on that. I think the Democratic Party would agree on this as well, because you also asked for the details of a service agreement. Now, secondly, in footnote 3, it is said that the number of cases to be received from HA per year is so and so. Then I believe this is a merit on the part of the CHK Medical Center. But I don't quite get it, because you're going to charge a fee. So I don't understand why it's regarded as a merit. So unless you are receiving cases from the HA, and that patients will be charged at the level of a public hospital's fees, or that the so-called middle-class cases would be taken up in a highly subsidized manner, so that the patients' cases would be dealt with more expeditiously with minimal fees. Can you explain more about that? Secretary, well, I will try to answer part of your question, and I'll see if the CHK would like to supplement. On type 2 babies, I'd like to clarify. Well, in the course of implementing the measure for type 2 babies, the private hospitals have been have been very cooperative with us. As for the second question, now, members asked questions today. We answered accordingly. Everything is on record. So we have everything recorded in the minutes, which are formal records. Chairman, I don't understand. I asked for the service agreement. I don't understand the Secretary's answer. I don't think he's answering my question. I was asking for the details of the service agreement. Well, Chairman, we haven't come to the stage where we can sign an agreement with the CHK. Well, without the loan, there is no agreement to sign. Well, the government, the CHK is subsidized by taxpayers' money. I think at least before you submit this proposal, you should give us a draft of the agreement, Secretary. As I said, anything about the agreement has already been included in the paper, and I've also answered your questions for clarification. Everything is recorded. So, Chairman, no service agreement. He hasn't even prepared a draft. He hasn't signed it. So, even when all the answers are recorded in the minutes, it doesn't mean that we have the service agreement available. Well, you're asking for the draft of the service agreement, and Secretary already answered that this will be implemented in the agreement, but he hasn't had the agreement yet. In the enclosure, we already set out some proposed terms in the agreement. Next. Assembly Lau, 3 minutes. Chairman, now our concern is that the public sector may be neglected, and I just received a complaint. It's about to be referred to the Prince of Wales Hospital. It's from a Sha Tin resident. Now, the resident was concerned about this possible cataract condition, and he consulted the GOPC, and then he was referred to the GOPC under Prince of Wales Hospital, and the hospital booked an appointment for him for the first eye examination on the 8th of July next year. And the patient is in his 70s, and he's about to go blind, and that is the problem. We see lots of problems in the public healthcare system, and you just don't make an all-out effort to handle the problems. I'm going to mail this to the Prince of Wales Hospital. I mean, earlier you already made allocation for cataract cases, and the situation remains. Now, in your enclosure, you talk about commitments undertaken by CHK. What if the undertakings are not fulfilled? What would be done? Secretary, well, first of all, cataract is a very good example for us to explain why we need the dual-track approach for public and private hospital development. And cataract in itself is an increasingly prevalent situation because of the aging population, and surgeries are required. Whether it's for medical consultation or for surgery, the queue for cataract cases is very long, and we also in the past invited eye doctors to work overtime and work night shift to clear the backlog. But once the situation slightly improved, then some residents or some citizens already originally opting for private services because of the shorter queue at the public hospitals would go back to the public system. So these cataract patients originally in the private sector would go back to the public hospital. That explains the long-standing long queues. And then we tried another initiative. We subsidized patients to undergo cataract operation in the private sector, and it has been quite successful. The queue is now much shorter than several years before, and we understand from this example that our commitment, whilst our commitment for the public hospitals remains for well, if those who wish to use private services could not do so because of insufficient capacity, they would go back to public hospitals, and that is the problem.
So we have to continue to plow in resources to make sure that the public system continues to develop. And on the other hand, we like to increase the capacity of the private system. We can go through PPP and the VHIS. So some who can afford it and who really want to patronize the private system can do so that we can provide some relief to the public hospitals situation. At this point, I'd like to be reminded about the second question, your commitment. This is quite clear. This commitment is pegged to the land lease. We have granted the land at a premium of $1,000 for a non-profit making hospital. If the hospital does not deliver its promise, the land can be re-entered. Maybe the PS can add. Even if we approve the loan, you can retract from giving the loan. Is that right? I'd like to refer to para 16 of the paper. The proposed government loan conditions and terms are summarized in enclosure 4. Could I refer members to enclosure 4? Those are the main conditions and terms proposed. They are only proposed because we cannot set out the details or sign any agreement before the FC says yes. There is this paragraph on safeguards in enclosure 4. It says how we can ensure that the CUHK will comply with the modified land lease and what actions can be taken. We'll take a break for 10 minutes. We will restart at 5:15.